Good afternoon, and welcome to the Mid-Atlantic Public Health Training Center and the DHMH's Public Health Practice Grand Rounds for July 2011. My name's Molly Mitchell, and I am the coordinator for the Mid-Atlantic Public Health Training Center. And I'd like to welcome you to today's presentation on home births and the public health response, promoting informed choices and healthy outcomes. Before we begin today's presentation, I'd like to invite our online participants to visit our website and see some of our online trainings, including public health, nursing, as well as many of our archived public health practice grand rounds. We'd also invite you to look at some of our upcoming trainings, which include next month's public health practice grand rounds on public health and the alcohol tax campaign, how Marylanders beat the alcohol lobby and why it matters, with David Jernigan and Vincent DeMarco. Also, we have Advanced Advocacy with Glenn Schneider on September 19th and 16th, and Logic and Planning Models with Carolyn Cumsty-Fowler on October 11th. And for those of you who are watching online, we invite you to email questions for either of our presenters at any time during today's presentation by simply clicking on the link on your screen. And we also ask if you wouldn't mind taking a moment to sign in. That way we have a better count of how many people are watching so we can let our federal funders know. And for those of you who are joining us in Sheldon Hall today, I invite you, if you have any questions for the presenters, to just write them on your index card that should be in your packets and hand them forward at any point during the presentation. And at that, I'm going to go ahead and introduce today's presenters. We have joining us from Boston by phone Dr. Jean DeClercq, who is a professor of community health sciences and assistant dean for DRPH education at the Boston University School of Public Health, and serves on the faculty of obstetrics and gynecology at the Boston University School of Medicine. He is one of the founders and current project directors of the PELL Pregnancy to Early Life Longitudinal Database. He was awarded a Robert Wood Johnson Investigator Award in Health Policy Research to study policy and practice related to cesarean section in the U.S., and has served as lead author of 3 national reports of women's experiences in childbirth and in the postpartum period entitled Listening to Mothers 1 and 2 and New Mothers Speak Out. We also have joining us today here in our auditorium Mari Breen Rothman, who has attended births at home, birth center, and hospital for 15 years, most recently with MAMAS, a bilingual green midwifery service, which she co-founded in 2007 with CNM Aaron Fulham. Mari holds a BSN from Catholic University, a CNM from the Frontier School of Midwifery, and an MSN from Case Western. Mari is a member of the American College of Nurse Midwives Home Birth Section, and is legislative liaison of the ACNM affiliate in Maryland, where she has helped pass a number of laws to make home birth and midwifery more accessible. Mari lives in Maryland with her husband and a gradually empty nest of 4 children, 2 of whom were born at home. So with that, we're going to go ahead and invite Dr. DeClercq to join us by phone. And so I'm going to hand it over to Dr. DeClercq now.
Great. Thank you, Molly, and thank you for inviting me to this. My primary purpose in this case is to provide background. And what I'd like to do is do a sort of brief history of home birth in the United States and try to put what looks to be the limited data that I have available on Maryland into a larger context. And I'll be glad to answer questions people have, either about contemporary data or some of the historical evolution around home birth in the United States, which I've also done research on. And so first and foremost, to understand home birth in the United States today is to understand that it's a function of the practices around it are a function of both public policy in different states, and they vary widely, and Mary will talk about some of those issues. And so institutional practices. And to put this in a historical context, if you go to the second slide, this is a rendition of the proportion of out-of-hospital births in the United States over the key period from 1935, when they were close to 2 out of 3 births in the United States, to 1970 when they reached the level of about 1%, a level at which they've stayed ever since. And what you can see is a rapid decline in the late 30s through the 40s. Most all of that entire decrease over the 35-year period actually occurs in the first 15 years. By 1950, the rate has gone from 65% down to about 12% in the United States. And while there's literature that suggests it's about professional battles between doctors and midwives, there's also basic institutional factors that influence this. If you go to the next slide, you should see why. This corresponds to the growth in hospitals in the United States. Nothing magical about that, and certainly the development of hospital beds, the increase in number of hospital beds wasn't a reaction to home birth by any means. It was an institutional drive that was happening in the United States. You see the bump there is tied into World War II. But if you go to the next slide, you see the conjunction between these two, which is the decline in home births, which is the blue line, and the rise in hospital beds, which actually has a strong negative correlation, not surprisingly. And so the movement of birth from home to the hospital in the United States is comparable to what happened in England a little bit later in this period, when a general drive to increase the number of hospitals in the country led to the hospitalization of birth as one of those elements. Now, there's other factors that moved it in, and if people are interested, we could talk about that. I don't want to ignore that there were political factors at work as well, and the next couple of slides deal with that. Excuse me. If you go to the next slide, there was a well-known case, not only in Massachusetts, but it became a national case around a midwife named Hannah Porn, leading to the regrettable court case Commonwealth versus Porn in 1907. And that was the case that outlawed midwifery in Massachusetts, essentially. And it was a cause célèbre at the time. If you go to the next slide, you see there was a whole series of newspaper articles and documenting the court cases. In all, Hannah Porn, who was a Swedish-Finnish midwife practicing in Gardner, Massachusetts, by herself, not as a group, as part of a group, and in fact was the only midwife in the town for most of this period, went from a new practitioner in 1895 to the busiest birth attendant in the early 1900s. In 1905, she's arrested for practicing medicine without a license and chooses to contest that, and contested through a series of 10 different court cases, virtually all of which she lost. The only one she won was an appeal on an expert witness. Every other case she lost, leading ultimately to the state Supreme Court, which in 1907 ruled that while she was a good practitioner by all accounts, and if you go to the next slide, you can see that, in an analysis we did of the outcomes of the birth she attended, her birth outcomes were at least as good as the doctors in the community at the time. And the social class, we don't have risk data on the specific births, but in terms of the social class of the clientele she served, it was at least as low or lower than that served by doctors. Her outcomes were fine. The Supreme Court actually said that, and said that while the state could establish, as they termed it, a line of demarcation between the practice of midwifery and the practice of medicine, that's not the intent of the law, hence she was practicing medicine without a license. Now, the decision in this case becomes important. If you go to the next slide, you can see that. This is data from another community in Massachusetts at the time. Well, actually, it's still a community in Massachusetts. But data from that period. And what you see is that the Porn case comes in 1907. Prior to that, midwives had been taking a larger and larger proportion of all of the births in the community. After that case, their increase stops and the portion of births attended by those midwives levels. The reason the data stops in 1914 is in September of 1914, all the midwives in the community are arrested and charged with violating the State Medical Practice Act under the ruling in Commonwealth versus Porn. They all, by the way, continue to practice, but they just go underground, it turns out. In any case, that sort of characterizes what the legal battle was about through this period of time. And by the 1920s, midwives are gone, and then you have the growth in hospitals abetted by, in terms of the midwifery issue, the establishment in the 1920s of nurse midwifery with an explicit model of having midwives work under the direct supervision of physicians. Now, let's move to the more contemporary period and look at these trends internationally, which is the next slide. And here you see the trends in a number of countries. You see the United States, which simply parallels the data that you've already seen. There's a couple of trends I want to note in this particular case. You see in the UK, which is the sort of orange line, the dark orange line, or reddish line, through 1950s, they're still at about almost 40% home birth, and then have a gradual drop. Their lines almost parallel the pattern in the Netherlands, except that there's a 25-year lag. In other words, in the UK, the rate drops to the high 30s by the mid-1950s. The Netherlands don't reach that until the 1980s, and the Netherlands remains the only country with a significant, only industrialized country, with a significant proportion of its births at home. Right now, it's at about 26% of all births in the Netherlands is still at home. And there's a big debate there among obstetricians and midwives, not surprisingly, over that issue, but there remains strong support in the communities around that. The other thing I'll note is the Japanese data, which I find intriguing. The very precipitous drop between 1945 and around 1960. And it turns out I was presenting at a conference, and I mentioned this data, and I couldn't explain the Japanese data. It was an international conference, and some Japanese researchers came up to me afterwards and noted quite clearly it was a function of the U.S. occupation, that one of the things that MacArthur and the U.S. did when they took over was wanted to upgrade birth in Japan and insisted on hospitalization. Okay, moving on. This is the trend in England, which again parallels the data, and I wanted you to see this simply because of that latter stages from the late 80s through the present of an increase in home birth. What's unique about England and Wales right now is it's the only country that's showing, industrialized country besides the United States, seems to be showing any significant increase in home birth. And if you look at the next slide, you can see it more explicitly. This is the last 20 years. And what you see is they go from about 1% home birth, which is what the rate is in a number of industrialized countries, 1% or less. And now they're up at about almost 3%. That the horizontal line with the sign changing childbirth that you see there reflects what was a major activist movement to encourage not only home birth, but more birth by midwives, giving mothers more choice and control over their birthing experience. The reason I highlight this is simply the fact that it's often cited in Britain that changing childbirth led to the higher rates of home birth. What this suggests is actually the higher rates of home birth precede the changing childbirth movement and are a harbinger, perhaps, of an activist movement that is just reaching maturity at the time of this effort. Okay, if you go to the next slide, we can take it to the United States and look at what the situation is in the United States. And go to the next one, you can see here's the proportion of all births that were born out of hospital overall. And that can be at home or in what are termed freestanding birth centers. And you can see a very gradual decline overall through the period of 1990 through 2004. When we present this data, you wonder why we started 1990. That's when, in 1989, the Standard Certificate of a Live Birth added a specific designation for home. Prior to that, one could only designate in hospital or out of hospital as birth. And so most of our data dates from 1989 or 1990 when more of the states had adopted the new birth certificate. What you can see is this period of about a 15-year decline, and then a slight bump starting in 2004, certainly in the home birth, not so much in birth center birth. People are interested to discuss birth center birth as well, although we're talking very, very small. If you go to the next slide, it looks more explicitly at home birth. And what you can see is from period 1991, where the data was a little bit clearer, we start with about 28,000 home births in the United States. So we're talking small numbers. This is a fraction of 1%, about 0.7%. And in the period from the early 90s through 2004, a remarkably steady decline in the data at about a rate of about 1/100% a year, all the way down to 0.56% in 2004 and about 23,000 births. As someone who does research on this, I noted between 2004 and 2005 there was a jump, and didn't know if it was anomalous. It could have been measurement error. It could be a whole variety of things that might have accounted for that. When it leveled in 2000, between 2005 and 2006, I thought maybe there's a little bit going on. In the last 2 years, it's jumped considerably, and we're back to rates comparable to what we had in the early 90s, almost a 20% increase in 2004 and 2008. And some of the colleagues I work with at NHS and I have published a piece on this if folks want to explore that further. If you go to the next slide, this is from a related study that we did in the 2003 revision of the birth certificate, National Certificate of a Live Birth. It added planning status, the home birth variable, and it simply asked whether or not the home birth was planned. And when we looked at that, not all the states have adopted the new birth certificate, as you all know, but and Maryland hasn't, may have right now, but through this period had not. And what we were able to do is look at, for the planned home births, which account for about 5 out of 6, 83% of home births in the United States that occur at home are planned. The primary people who are attending those are CNM, not so much, certified nurse midwives and other midwives, and other. In other words, of the planned home birth by attendants, what we don't see is doctors being involved in them. For the most part, when doctors were involved in a home birth, in 69% of the cases, it was an unplanned home birth. When a CNM was involved in a home birth, it was almost always a planned home birth. Likewise for another midwife. And then we have this other group incredibly called other, which refers to non-nurse midwives. And it might be nurse midwives. We don't know. People always assume that's sort of taxi cab drivers, people, EMTs, and that kind of thing. The likelihood is that probably midwife states where the restrictions might be so pronounced that fathers will sign off the birth certificate, those kinds of protect midwives. Go to the next slide. You see the breakdown by race ethnicity, and I think this is notable. Well, first maybe look at the right-hand column. In the hospital births, that's the distribution. Essentially, since it's more than 99% of the births, that's the distribution of birth in the United States by race. About 26, 27% Hispanic, large proportion white, smaller proportion black, and smaller proportion Asian Pacific Islanders or American. In the unplanned home birth, it is somewhat parallel to that, the far left column. Planned home births in the United States are white, non-Hispanic, essentially. Very small number of Hispanic, very small number of the other groups, and overwhelmingly it's white, non-Hispanic mothers. I should note that the increases we've seen in home birth between 2004 and 2008 have occurred almost completely. Over 90% of that increase has come from white, non-Hispanic mothers. So we have a shift in the racial distribution of home births in the United States in the last few years, to the point where, as you'll see if you look at the next planned home birth in the United States. And there's a few things that I'll note. So, again, the three columns, the first column is unplanned home birth, the second would be planned home birth, and the third would be hospital birth. Again, that's pretty reflective of the country as a whole. And so if we just look at the planned home birth mothers, you find that they were older. About 52% of them are over 30. They're overwhelmingly married. They're rarely foreign-born. 91.5% are native-born, whereas about a quarter of all other births are all foreign-born mothers. They're almost all full gestation. 97% are full gestation. Go to the next slide. They're more likely to be in rural areas. They're not too likely to have reported no prenatal care. They're overwhelmingly non-smokers. And they are incredibly well educated, 55% having at least 1 year of graduate education. And so the people having home births in the United States now are a pretty selective group. And they're well educated. They tend to be professional. And they're making a very considered decision around their home birth status. Not shown here, but another factor in all of this is if you look at parity, in about 75% of the cases, they tend to be mothers who have given birth before, and presumably that's going to mean birth in hospital before. Go to the next slide. Percent of home births by attendant. With time, let's just look at 2008. And you can see this is now the distribution of who's attending home birth in the United States. 2008, and this is all home birth. This includes the unplanned because we weren't able to distinguish it. We used all of the data, all of the states. You see that it's the primary group is other midwives. Again, these are primarily certified professional midwives. Mary can talk to that. Other is the second largest category, about a third of them. That's up a little bit since 1990, but a significant portion of it. CNMs have dropped off. If you do the comparison, see whereas CNMs did about 40% of the home births in 1990, did down to about 19%. That's off because of legal constraints in given states around CNM's ability to get backup insurance home birth. And physicians by 2008 rarely did home birth, again, for some of the same reasons that CNMs work within those areas. Go to the next slide. This is the growth of the birth to other midwives. This is the CPM group, with about a 57% increase between 1996 and 2008. If you see there's that little jump in 2007 where it jumps and then goes back down, that's probably measurement error, actually. That some of the CNM births were attributed to other midwives that year, and that's been cleaned up. You actually see it's a pretty consistent trend, however, for a substantial increase in CPM. And in the policy world, they've been much more active than any other group in terms of advocating for home birth and pulling together the coalition that supports it. If you want to see what the impact of changes in the U.S. system is in light of home birth, look at the next slide. What this illustrates is the gestational age distribution in the United States. And you see two groups there. In red is the gestational age distribution of all births in the United States. And what you see is the shift we've had, that in fact the average or the modal gestational age now is 39 weeks. And it's a fairly normal distribution after that, going down to 38, 40, 41, and 37 from that point. If you look at the planned home birth in the United States, what you see is the old classic distribution. And I think this is with the peak at 40 weeks and a normal distribution centered at 40 weeks. And what this illustrates is the shift we've had in the United States. By the way, if you do the same thing with 1990 and 2008, the 1990 pattern is very much like the planned home birth pattern in 2008. And so we've sort of normalized 39 weeks as the optimal gestational age. The planned home birth suggests that's not necessarily always going to be the case. Now let's turn to Maryland. The last few slides here focus on your state. you go to the next slide. This is the percentage change in percentage of home births by state in two of the most recent periods. And you can see Maryland is one of the states with a statistically significant increase. You'd also be hard-pressed to find too much of a pattern in this, beyond maybe some cluster in mid-Atlantic states, but not much beyond that in terms of states with significant increases. And in the case of the states with significant decreases, a couple of those instances, those are states that had very high rates already and decreased slightly, but still with very high rates. Utah has one of the highest rates in the country. If you go to the next slide, here's the pattern in Maryland over the last almost 20 years. The U.S. rates are there for context in red, but the Maryland rates, there's a jump in from 1992 to 94, but then a continual decline from that point all the way to about 1999, and then the beginning of a gradual increase that seems to accelerate again in this last 4 or 5 year period. To put it in context, among all of the states in 1990, Maryland was ranked 34th in proportion of all births at home. By 2000, Maryland had dropped to 45th nationally in proportion of all births at home. By 2008, they're back at 34th. Still small numbers. You're saying, how small are those numbers? Look at the next slide. We're talking 381. And understand, because Maryland doesn't have a planning status variable on it, these are home births that occurred at home and may include unplanned home births. If we have the normal distribution of about 85% of home births are planned, then you're talking somewhere on the order of 330 or so. Now, the other piece that should be noted is not all planned home births end up at home. Obviously, some of them involve transfers to the hospital, and the birth certificate doesn't pick that up at all. The transfer rate, the intrapartum transfer rate for home birth, roughly, it varies widely, but it's roughly in the order of about 15%. So to some extent, it averages out between the unplanned home births that get counted in this group and the planned home births that end up in hospitals. But in terms of outcomes, we can't simply lump them all together. If you look at the breakdown in Maryland of who attends home births, you see something that's pretty distinct in the United States. The far right column simply mirrors the pie chart that you saw earlier. The Maryland data suggests a larger number of physician-attended home births, a much larger portion of CNM-attended home births. And I suspect that the biggest difference, of course, is the other midwife category because of legal constraints in the state. Other has a smaller grouping. So this could be because either by definition, the others pick up some of the other midwives. And you all can probably speak to that, and the next speaker will be able to speak to that more in terms of that distribution. It's pretty unique in the United States. If we take a look at the next slide, you see the race-ethnicity breakdown in Maryland versus the United States. A much higher proportion of black, non-Hispanic births at home in Maryland. And the rest of the distribution is similar, assuming some of the white portion is lower, but in the other categories, fairly close. Now, again, we don't know. Black mothers are much more likely to have unplanned home births. And so we can't really say the extent to which this is characteristic of a larger than average national population of black mothers and more unplanned home births happening in that group. That's it. That's the end of mine. Again, I'll gladly discuss this with anyone who has questions, but I think we'll turn to the next speaker and see her presentation.
Okay. Thank you very much, Dr. DeClercq. We're going to turn the floor over now to Mari Breen-Rothman.
Hi, everyone. Hi out there in computer land. Thank you so much for inviting me to come and talk about this subject, my favorite subject today. First thing I want to say is not much has changed in the issues since Hannah Porn. Midwives are still giving excellent care at home the way they were way back then, with outcome statistics similar to hospital births. And we're facing some of the same issues in terms of constraints of practice. The first thing I want to do is define some terms here so we're all talking about the same thing. When we say planned home birth, we're really referring to births that take place after a period of prenatal care with a trained provider, and then a birth that is planned for and prepared for at home, where everything that's needed for a safe birth comes to the home and is there available for the midwife to use. Defining midwife, it gets a little fuzzy. There are several kinds of midwives currently operating in the state of Maryland. One is a certified nurse midwife, which my partner and I are. We are midwives who are dually trained in nursing and midwifery, and practice midwifery according to the standards of the American College of Nurse Midwives after completing a program of study accredited by the ACNM and sitting for an exam that is administered by the American Midwifery Certification Board. A CPM is a certified professional midwife. This is a person that's completed a program of study under the guidelines of the North American Registry of Midwives and has completed their certification exam, which is also another kind of rigorous program of study. When we talk about unattended home births, really an unattended home birth is attended by somebody, usually a family member, and people that choose to have unattended home births I'm distinguishing them from unplanned home births because sometimes people do plan to have an unattended home birth. And there are a lot of complicated issues that lead to that decision, but one of them is not having the availability of a midwife or the resources to pay for one, and having the conviction that the safest place to be for their birth is in their home. About 3 to 4% of births in this state take place outside of the home, and those take place in either birth centers outside of the hospital, and those take place either in birth centers or at home. So I wanted to talk a little bit about the differences between home and birth center births, because I think a lot of people think of a spectrum of the use of technology as being home birth on one end and hospital birth on the other end, with birth centers somehow sort of in the middle, when in fact birth center births are like having a home birth at somebody else's house, which is great because you don't have to clean it before your birth, but there's nothing there that a midwife wouldn't bring to your home if you were having your baby at home. Two differences, some similarities are that they both involve trained midwives who have available and know how to use resuscitation equipment, oxygen, IV setups and fluids, medications for hemorrhages, antibiotics, sutures, local anesthetics, all of those things. And they both offer very close follow-up after delivery, 3 to 4 hours of acute care after the birth compared to a 60 to 90-minute acute care period in the hospital. And then round-the-clock family care, 24-hour phone consultation, and several postpartum visits in the first 2 weeks. The differences, there are two major differences between hospital births and birth center births. One is that in a home birth you don't have any institutional bacteria, and the other is that birth centers require a pregnant woman and her nervous partner to get in a car and drive somewhere while they're in labor, and to get up and go home after a few hours. So, next slide. No, that's not what we're doing. Yeah. So I wanted to talk a little bit about the safety of home birth, because when people are trying to change policy and laws to allow women greater access to home birth and to midwives, the biggest argument that they bring up is that it's safer for mothers and babies to be in the hospital. And in fact, there's really no science to back that up. The safety of home birth has been established since Hannah-Porn, and we've had multiple studies in the last 10 years that have established the safety of home birth again and again. But I'm just going to review a few of the most recent studies for those of you that aren't familiar with the literature. I also want to point out that there is I don't know if this is visible to those of you at home, but this is called Home Birth, an Annotated Guide to the Literature, that was authored by Saraswati Vedam. Dr. Vedam is a professor at the midwifery program in the University of British Columbia, and she and her colleagues produced this amazing compendium that's an annotated bibliography of articles in scholarly journals regarding home birth. And that's something that I really recommend for anyone that's researching this topic. As far as these studies go, in Olson, 1997, in the journal called Birth, Olson found no statistical difference in mortality between planned home and planned hospital births, and found fewer medical interventions, fewer severe lacerations, fewer operative births, and fewer low APGAR scores in the home birth group. Johnson and Davis, in the British Medical Journal in 2005, found that home births had a 12% transfer rate, a 3.7% C-section rate, and a 1.7 in 1,000 neonatal mortality rate, as well as lower intervention rates for the planned home births than for the low-risk hospital births they were being compared to. In the Journal of Perinatal Education, Leslie and Romano compared home births, planned home births, birth center births, and hospital births, and found that both of the out-of-hospital births, whether in birth center or at home, had similar perinatal outcomes to the hospital births, but with fewer interventions to achieve the same outcomes. In 2009, Jansen and Saxel compared outcomes of midwife-attended home births, midwife-attended hospital births, and doctor-attended hospital births. And all three of the study groups had to meet the criteria for a home birth, so the three groups were similarly low risk. And in fact, all three groups had the similar perinatal death rates and similar or reduced adverse outcomes in the home birth cohort. By the way, the women who were transferred from the home birth cohort to the hospital were retained in their original cohort, so even when they were transferred, they did as well. The home birth group also had fewer intrapartum interventions even when transferred, including narcotic and epidural analgesia and instrumental or cesarean delivery. The home birth group also had lower rates of postpartum hemorrhage, fever, and severe lacerations, and their babies were less likely to have low APGAR scores of less than 5 at 1 minute and were less likely to need drugs for resuscitation. There have been a number of studies done in the UK, Switzerland, the Netherlands, Australia, and others that have found similar findings internationally. There is one study I want to mention, which is the one done by Wax and his colleagues in the American Journal of Obstetrics and Gynecology in 2010. This generated a lot of heat because Wax found a 2 to 3 fold increase in the infant mortality rate in home births. And the study is called a comparison of planned home births and planned hospital births, but in fact, in the study, it's a meta-analysis of a number of studies, and they included studies that didn't differentiate between planned and unplanned births at home, which skewed the data quite a bit. They also included preterm infants who were delivered at the hospital. They included data from birth certificates that didn't differentiate between planned and unplanned, and they also did not consider culture and geography and healthcare systems as for their impact when consolidating smaller studies that had very small samples. For a more detailed critique of that study, you can go to this website that you see there that's in your packet, I'm sure, and see what a bunch of experts in the field, including authors of the studies that were included in the meta-analysis in that posting. So why are women choosing to have their births at home? I think that the surge in home birth, it has to be noted that the surge that Gene showed on his slide coincided with the release of a film called The Business of Being Born. And if you haven't seen The Business of Being Born and you're talking to people about home birth and why they're choosing home birth, you're missing a big chunk. You can get it on Netflix, and I really recommend that if you haven't seen it, that you see it, because it had a huge impact on women. My partner Erin and I started our practice right around that time, and when women would transfer to us, we would ask them, what made you decide to come to us? And I'd say 9 times out of 10, they would say, well, I was going to an OB and planning a hospital birth, and then I saw The Business of Being Born. I can't tell you how many times I heard that happen. And what began to happen is that they began to look at the data, not just from that film, but it led them to look into it further, because everyone has the internet now, and people research everything. A study done by Boucher and Bennett in the Journal of Midwifery and Women's Health in 2009 found that the number one reason that women are choosing home birth is because of safety. That is their primary concern. There's been a lot of literature recently about how women are choosing home birth because they're self-indulgent or because it's like a spa birth or cause celeb or whatever. And what this study found with a large number of women is that the primary reason for choosing home birth is safety, followed by avoidance of unnecessary medical interventions, a previous negative hospital experience, and a comfortable, familiar environment. The women in our practice cite the rising C-section rate in hospitals, the low C-section rate in planned home births, and even more, they cite not feeling listened to and having their wishes respected by hospital-based practices. They look at the evidence and make their choices. They see that in our hospital-based culture, we don't value the natural process. We think we can induce labor and replicate the process with technology and drugs, and everything will just come out fine. But the science tells us that this is not so. What we find is that for all our technology, we rank poorly compared with other developed countries when it comes to outcomes. We spend more money per capita on maternity care than any other country in the world, and yet when a woman goes to one of our state-of-the-art hospitals, she has a more than 1 in 3 chance of having her baby delivered surgically after a greater than 50% chance of being induced or augmented with Pitocin. And when women are induced, their chance of a C-section is 2 to 3 times greater. As Jennifer Block, the author of Pushed, puts it, what we start with drugs and technology, we have to finish with a scalpel. We have evidence that one-on-one support, light nourishment, moving around, and getting in different positions, being in water, all of these things help the process of birth and increase the chances of delivering vaginally and needing fewer interventions. But we just ignore the evidence. We know all of our interventions don't improve outcomes, but we just keep on using them. Women look at the evidence and make their choices. The average home birth practice has something around 95% normal vaginal deliveries, close to 100% breastfeeding rate. When your cat has kittens, do you remember when you were little and your parents said, don't touch the kittens for a week? You're not supposed to touch the kittens for a week because the moms might not take care of them and they'll get confused and not know how to nurse. Well, after all, we are also mammals, and it's probably best not to touch the baby or take it away from its mom for about a week after the baby's born. In home births, there are also low rates of induction, episiotomy, epidural, newborn infections, and a very low rate of complications for newborns and moms, and no separation between babies and parents. And that's what women are looking at now. So, 30 years ago, we may have had a majority of home birth moms being the back to the land, back to nature, granola moms, but that is not who's having babies now. Now we have Hill staffers and MBAs and Army sergeants and a surprising number of healthcare professionals are choosing to deliver at home. Well, maybe not so surprising. So I've lost my place. Oh, this is what they don't want, is what's routine now. Well, yes, it's a routine procedure. If you routinely have someone slice open your body with sharp instruments, then fiddle with your insides. So who is attending home births in Maryland? There are CNMs delivering in Maryland, but they are having challenges. It's difficult to get licensed in Maryland because of the hoops you have to jump through with the Board of Nursing, which were recently made a little bit easier by a change in regulations, but it's still difficult. It's difficult to form relationships with physicians and hospitals who are afraid of being liable for the births that are happening at home. And there's no regulation in the health insurance industry so that people are not getting reimbursed for home births, which cost about a third of a hospital birth, and yet Blue Cross Blue Shield that will cover 100% of your hospital birth will cover maybe a third of your 30% cost for that. Also, home birth in Maryland is not covered by Medicaid, so that means that it's only available to people who have enough money to either not use their insurance or go out of network and pay a big chunk of it themselves. There are CPMs working in Maryland, but they're working outside the system and are afraid to transfer people to the hospital because of lack of support from the medical community and because they're operating illegally. So from a public health standpoint, that also presents problems registering births. The licensure of qualified CPMs would eliminate birth registration problems and hold them accountable for their practice, but that is not happening in Maryland at the moment, although it is in surrounding jurisdictions. And then there are also unattended home births, but I think that constitutes a very small number. I think the other that Gene had on his chart was probably more people having their babies with CPMs and keeping it underground. So the public health issues involved in home birth are that women are choosing home birth in ever-increasing numbers. Women will choose home birth, whether they're attended by a CNM or a CPM or their friend who lives down the street or whatever, because that's what they've decided they want to do. So the challenge is to make it as safe as possible. The ideal public health scenario would be that everyone who's qualified to attend births would be licensed without having to jump through unnecessary hoops, so that everyone is operating inside the healthcare system. Everyone has access to the model of care she chooses. Ideally, a woman would be able to call her OB and say, I've decided I'm going to have my baby at home. And her OB would say, oh, great, let me refer you to a good midwife. In the ideal situation, we have enough midwives because they would feel welcome to practice in our state. We do not have unattended home births, so births can be officially registered and recognized by birth professionals. We have a streamlined way to transfer women from home to hospital when needed, and midwives are able to consult or collaborate with physicians without fear of legal repercussions on either side, because the physicians are also afraid of being held liable for the actions of the midwife. And also in that ideal situation, Medicaid would cover services that women choose and also save the state a lot of money. Let's consider for a moment the situation in New Mexico, where 28.5% of their births are attended by midwives. New Mexico is one of the very few states where midwifery has never been illegalized and re-legalized. They've always been considered legitimate healthcare providers there. They're actually doing 36% of the vaginal births in that state, and New Mexico has the third lowest C-section rate in the country. They also have a lower infant mortality rate than 34 other states, and Washington State, which is another state with liberal access to midwifery care and home birth, has the lowest infant mortality rate in the country. So the next steps that we need to think about are, there has been a suggestion that we have a future webinar on the history of regulation of midwives in this state, CNMs, CMs, CPMs. And what we really need are some roundtable discussions among physicians, nurses, midwives, public health officials, and members of the insurance industry, and most importantly, women of childbearing age. We need to discuss ways that we can support a woman's right to choose her model of birth care, her birth attendant, and her birth site, while being supported at all levels of the healthcare system. I was recently on the Kojo Namdi show, an NPR show, and during the day they have little leaders that they play to entice people to listen to a show that's coming up later. And I was alarmed to hear that the leader for the show I was going to be on was, should women be allowed to give birth at home? And that question has been ringing in my mind, because I was trying to imagine if I had ever heard a question that started with, should men be allowed? Should women be allowed? Should women be permitted to do this or that or the other thing? It's just not something that we say about men. We say it about women, we say it about children. And so I think that is a fundamental thing that we need to get past. We need to be asking, should women be supported to have home births, not should women be allowed? And clearly, in the interest of public health, they should be supported in that endeavor. The bottom line is that birth is about women, and this discussion is really about the sovereignty of women. As Kitty Ernst says, who's a famous midwife, mover, and shaker, if we take good care of the mothers, then the mothers will take care of the babies. I gathered a lot of data for this talk, and I was really struck by how much work has been done in that area. We have had researchers prove over and over again the safety and cost-effectiveness of home birth, and so I really want to just give a thank you to Jean DeClercq and his colleague Marion McDorman, to Sarasvati Vedam, and also to Jennifer Block for their tireless work in gathering comprehensible information for us. I'm not sure how many more times we'll be called upon to prove yet again that home birth is safe, but I'm confident that they will make it possible. And I'm sure that Jean and I are both happy to hear any questions that you might have.
Thank you so much, Mari and Dr. DeClercq. At this point, we are open for questions, both from all of you who are here with us in Sheldon Hall, as well as those online. And for those of you who are here with us, if you'd like to fill out on your index card any questions that you might have and pass them forward to Janie. And if you're online, you can simply click on your screen and email us in any questions that you might have. So, and are you still with us, Dr. DeClercq?
Right here.
Awesome. Okay. Great. What I'd like to go ahead with is we do have a couple questions from our online audience, so I'll start with those. And I think this is for either Jean DeClercq or Mari. The question is, what were the demographics of the women in the studies that were cited in lectures to show no difference in birth outcomes in home births? And does this impact the data results? And also, what is your opinion of the ACOG defined criteria to define a high-risk pregnancy, specifically VBAC in age over 40 years? So I don't know which of you wants to take that one.
I'll take the first one if Mary will take the second one.
Okay.
In terms of the demographics of the mothers in the study, obviously there's no randomized trials of home birth. Amazingly enough, women don't let themselves be randomized to a home or hospital birth, so we can't have that. So what they have to do is retrospective studies of the women who have had home birth, and what typically happens in these studies is matching. And trying to match them to a comparable low-risk hospital population. The biggest limitation in these studies is that, again, we oftentimes can't distinguish the planned home birth, the bias, as I mentioned earlier, on both sides, whether or not a home birth was actually a planned home birth or not, and on the other side, those home births that end up in the hospital. Now, there are studies that have dealt with that, and when they have generally found the kind of comparable results that Mary was referring to. The biggest study that's been done to this point was done in the Netherlands, not surprisingly, because they have the largest number of home births. And in it, they found no differences in the perinatal mortality rate between home birth and low-risk hospital birth. Excuse me. And no differences in neonatal mortality rates up to seven days. The other variant in this is in the Canadian studies that were referred to, they were able to, since midwives continue their practice work both in home context and hospital context, they were able to do a comparable design using midwife-attended births in homes and hospitals, including midwife births that have started at home and ended up with the transfer to the hospital. And so the findings have been pretty consistent around those findings, but it's not a random population by any means. Again, it tends to be a self-selected group that has home birth.
I'd like to add something to that, too. I don't think this is on. Now it is. This? There we go. There was a study done, I believe, in 1997, but I bet Jean knows, that was published, I think, in the National Journal of Epidemiology, and it was sponsored by the CDC. The author was Marion McDorman, and it was a retrospective look at 3.2 million births in the United States. And in that study, she very carefully controlled for socioeconomic status, age of the mom, how many babies she'd had before, educational level, race, every parameter that you can think of, except was she cared for by a physician or a midwife during her care, during her prenatal period and her birth. And what that study found was that women who were being cared for by certified nurse midwives had a 19% lower infant mortality rate and something like a 31% lower low birth weight rate. And the conclusions that were drawn in that study were something that would translate into a home birth setting as well, which is that midwifery's care is designed to optimize the woman's care of herself during the prenatal period, to make sure she's getting adequate nutrition, rest, exercise, all the things that make for a healthy pregnancy and encourage the baby to stay inside until it is not low birth weight anymore. So when you're looking at studies of populations in a home birth setting, you're always going to be looking at women who are at low risk for problems in their births. And in these studies, they compared the home birth groups to similar low-risk populations in the hospital. The second question was about risk criteria and risk screening for home births. Home birth midwives are extremely careful in selecting women for inclusion in our care because we don't want to have a problem at home, and we don't want the woman and her baby to have a problem at home. Age by itself is not a risk factor for anything except for genetic defects. So that's not, we wouldn't risk someone out just because of their age under normal circumstances. And I feel like the issue of VBACs is a whole other issue that we probably can't get into today because it's really extensive. But it has been pretty much established that a VBAC is a reasonable choice for many women under the right circumstances.
Okay. We've got some questions and comments, I think, about Medicaid. And one is from the Department of Health and Mental Hygiene, the State Department of Health in Maryland. Not a question, but a comment that Maryland Medicaid does cover home/birth center births. Additional information can be obtained on their website. And then there's also a comment from our live audience about federal mandate for home births. I'm not sure what that refers to, if you want to clarify.
While she's coming to the mic, let me just respond to the first thing that you said. It may be that on paper Maryland Medicaid covers home births, but in order to cover that service, you have to find a provider of that service who is covered by Medicaid. And it is very difficult for home birth midwives to be on the preferred provider list of Medicaid MCO because we typically only have 6 to 10 clients a month, and Medicaid reimburses at such a low level that it isn't sustainable for us to keep practicing when we're going to be paid, a quarter to a third of our fee.
Go ahead.
Hello, everyone. I'm Karen Fennell. I'm currently the federal lobbyist for the American Association of Birth Centers, the freestanding birth centers, and for 14 years, the lobbyist for the American College of Nurse Midwives. We are finding there's a lot of confusion among the midwifery community on payment as it relates to Medicaid. Actually, every state is required, even in their MCOs, to pay for the services of a nurse midwife, whether it's the MCO that is paying the Medicaid fees, an HMO, whatever it might be, there is a requirement. We have been challenging that around the country now and winning case after case. The big problem we have in Medicaid is the same problem we have in the freestanding birth centers, in that payment does not cover everything. So as she just stated, you get a professional fee. However, the professional fee does not cover those other overhead costs. In the birth centers now, under the Healthcare Reform Act, we have just gotten a mandate that now the states under Medicaid must pay what we call a facility service fee. That would be, if you compare a birth center to a hospital, the hospitals, their providers, their physicians, and other independent providers get paid a professional fee, and then there is a service fee that all hospitals receive to pay their overhead costs. But I'd be glad to work with you on the MCO problem. Thank you.
Great, thank you. We can take any other questions that we might have here in the live audience now. Oh, that's right, we're taking them by cards. Okay. There was another question for Dr. DeClercq. In your opinion, does the socialized medicine structure in England have any impact on the trend toward home birth there? And is there provision for home birth support in the recently passed health care law in the U.S.?
In answer to the first question, no, not particularly. It's not a function of the nature of their system, except to the extent that what they did in England was set up an integrated system of care. As part of that changing childbirth movement I mentioned, what they did was allowed mothers who wanted to have a home birth to actually be able to plan with the midwife for the home birth with appropriate backup. Ideally, what you like is to have an integrated system with midwives trained in doing home births, backed up by physicians in cases where complications arise, and that if a transfer has to occur, it occurs seamlessly. And they did that, and they worked through all of that. So, in and of itself, I don't think the system caused that, but the nature of the system allowed them to plan more completely. When you look at the actual data on home births in England, though, you still find that it's concentrated. While the overall rate is around 3%, it varies from some districts where it's 10 or 11%, oftentimes more rural districts, and a handful of urban centers that have practices, to very small proportions in other areas. So a mild yes, I guess, is the question overall. In terms of the new health reform, I didn't see anything in it that would make a difference. Myri might be able to answer that. Actually, Karen might be able to respond to that as well.
Okay.
I think Karen is coming to a mic. I think Karen's probably the best person to answer that question in this room at the moment.
Karen Fennell again. Actually, the Healthcare Reform Act does one very, very significant thing for pregnant women, and that is pregnant women that do not have health coverage will, as the reform gets phased in, no payment for their services, pregnant women's services will be paid for, whether that's in the exchange or the expansion of the Medicaid population. The other thing was it is the first law at the federal level in the United States to pay for the professional fees of the certified professional midwife, but only in a birth center. We also saw another significant, which sets a policy piece for the certified nurse midwife, and that's in the Medicare program where they do see women with disabilities, but Medicare has been the standard of payment for private payers and other public payers in our system, and now the certified nurse midwife has been recognized at being paid at 100% of the physician fee schedule. Thank you.
We have another question from our online audience asking about whether there have been any studies that have examined endpoints other than mortality. Hypoxemia might be a more frequent occurrence and occur at different rates in the planned home birth versus hospital birth study populations.
I'm not really sure why hypoxemia would be more of a problem in a home birth than in a hospital, and in fact, it strikes me as unlikely because some of the risk factors for hypoxemia would not exist. For instance, the effects of the mother having taken narcotic analgesia during labor, or similar interventions that could cause that to occur, are less likely to happen in the home birth setting. But I'm not aware of any studies that have specifically looked at that parameter. Are you, Jean?
Offhand, I think there have been some that looked at outcomes, but generally they find two things: that the outcomes are comparable overall in terms of health outcomes, and that interventions are less that in the home birth population in terms of obviously fewer inductions and fewer use of different forms of anesthesia. And even when you add in transfers, fewer cesareans overall.
Yeah. I mean, if you look at one of the things that has been looked at in a number of studies is APGAR scores, and I would think that would be reflected in APGAR scores. And they've done similarly, although in some studies there are fewer very low APGAR scores in the home birth population. Less than 5 in the first minute is less usual in the home birth setting.
Okay, just 1 second. There's a question about what, and I guess this is directed to either of the presenters, what you might think about the work of Paul Starr in the social transformation of American medicine and the movement of births to the hospitals and keeping them in hospitals.
I'm, like many, a fan of Starr's work. I usually tell my students that I still encourage them to read it. The book's got to be 20 years old by now. But that he does a superb job of looking at the issue of the transfer of birth from home to the hospital. And as a researcher, one of the things that most impresses me is I do know that literature and I am familiar with it. And oftentimes I find when I read other books, general books that have a section on birth, I'm very impressed with the book till I read the section I actually know something about, and then I find that it's flawed in a number of ways. And the reverse was true. Case of Starr, that I was impressed with the rest of the book, but when I saw the area that I'm most familiar with, I was even more impressed with the quality of the scholarship there. So I would highly recommend it as a source to look at in terms of putting the movement of birth into the hospital in a larger context.
Do you have anything to add? Or?
Nope.
Okay.
Did Paul Starr send that question, by the way? I just checked.
No, it wasn't from Paul Starr.
Can I just add one other thing?
Sure.
One of the nice things about being in my office is I just looked up one of the major study, that Dutch study on outcomes that they looked at. They also looked at NICU admission and found no differences there either between the home or the low-risk hospital birth population.
Okay.
I think that the overarching thing we need to look at in that is that we concentrate very heavily our attention on the something like 3% of babies that need some kind of help. And the truth is, for low-risk moms in any setting, about 97% of the babies are just fine. And so what's really important is to have emergency pathways set up to deal with the babies who need some help. And one of the best things that we can do for home birth and for women who choose home birth is to make sure those systems are in place so that we support that choice instead of just telling them you can't have that choice, and if you do, we'll punish you by not letting you access the medical system.
Okay. And this is another question for Dr. DeClercq. You mentioned that a recent study showed that about 20% increase in home births, and I'm wondering if you could comment on the long-term predictions on this, whether that will continue or...
I'd be incredibly rich if I could make good long-term predictions. So I don't want to say how high it could go. I think the British situation is instructive in that in a system that actually supports home birth, and by supporting home birth, it means simply don't have a whole lot of systems arrayed against it, but give people a real option to do that. They're at about 3%. I would think at a maximum in the United States, given what has been a much more historically antagonistic view of home birth, that you might be talking at some point of getting up to 1 and 1.5%. But I wouldn't want to bet a lot on it. Again, if you look at that slide, it decreased at an incredibly slow rate, 1/100% a year, and even that 20% increase is on a very low base. So I don't see a huge shift happening in the immediate future, but again, this may well be the harbinger of a much more activist maternity movement in the United States.
I often refer to it as a quiet revolution, because I actually think that we're reaching some kind of a tipping point where the increase is going to come a lot more quickly. Women in labor ask me all the time, how much longer is this going to be? And so I've learned not to make predictions of exactly how long, how much, how much does my baby weigh? I have no idea. But so I'm not going to make specific predictions, but I do think that the combination of the rising C-section rate and women moving into the workforce in a way that they haven't done previously, the young women who are coming up now, like my own 2 daughters, who are telling me things like, Mom, the word feminist is outdated. We're not interested in feminism. We're interested in gender equality. And the way that they're thinking now, the way that they would look at someone who told them what to do in any situation is really affecting obstetrics. We recently had a client who came to us because she did a lot. She didn't know anything about birth when she got pregnant, so she did a lot of reading, and she went to her beloved OBGYN who had been doing her pap smears for the first 10 years of her woman life, and said, I've been doing some reading and I think I want to have natural childbirth. And he reached over and patted her hand and said, no, you don't. Trust me, you don't. And that was her last visit there. And he probably will never know why. And that's why I call it a quiet revolution, because women are quietly examining their options, and they're looking at research and science, and they're making their choices. And I think that's just going to be more and more true as time goes on.
Okay. There's a comment here, and maybe Mari can address this. I was surprised to read that 26% of home births in 2008 in Maryland are attended by physicians. Where are these physicians?
I don't know anybody who's had a home birth attended by a physician. I don't know every birth that happens in the state of Maryland, but that's... I see Karen nodding her head. I don't know. I have no idea who those people are. I've lived in Maryland and been involved in the birth community for 24 years, and I don't know of a single case of a physician-attended home birth offhand. Maybe someone else knows of those.
Okay.
Again, there's a couple of things that could be happening there. One is it could be unplanned home births that ultimately may be transferred as a hospital but get checked as a home birth because they started there. And the physicians end up being on the birth certificate for that reason. Yeah, we're talking pretty small numbers, but they're real.
Yeah.
The other may just be a sort of a sign-off. I'll tell you a quick story. When I was doing the historical research, I interviewed a physician whose father had been one of the physicians at the time when I was studying. This was a number of years ago, and this man was quite elderly, and his father had actually been one of the leading physicians in Lawrence, Massachusetts in the turn of the century when midwives were being driven out. And I noticed that the birth certificate, that he had signed a lot of the birth certificates that I knew for a number of reasons were actually midwife-attended births. And I asked him about the relationship they had with midwives. Did they share practices? Did they cover for each other? Was there payment involved? That kind of thing. and I had all these questions about the relationship that they had. And he got very angry, and he said, my father hated the midwives. He didn't want to have anything to do with the midwives. And I pointed out that he had signed a lot of birth certificates that had been midwife-attended births. He said, sure, the midwives go in and they attend the birth, and they take care of everything, they clean up, and then they have the parents call my father to come in. And he'd come in and he'd sign the birth certificate, and he'd only get $5 instead of the $10 he usually got. We hated the midwives. So I don't know if that's still happening in some respects.
Yeah, I really don't know. I think it has to be a function of I mean, that comes from birth certificate data. Is that right, Jean?
Yeah, and that's 100 out of 77,000 births. So,
yeah, so who knows how that ended up being put on the birth certificate that way. But I would bet that it does not reflect a physician going to a woman's house when she's in labor, waiting for her to deliver, catching the baby, cleaning up, and then signing the birth certificate.
I mean, when Maryland adopts, and I don't know if they've adopted it yet. I know as of 2008 they hadn't adopted the new birth certificate. But once they add that item to the birth certificate, then they'll be able to check that against
it is there now.
Planned home birth.
It's there since they went electronic, which was like, a year and a half ago or something?
Okay. We have a comment, and maybe Mari could add to this or respond. During the years 1994 to 1995 in Maryland, 5 midwives, not CNMs, were charged with practicing nursing midwifery without a license. These midwives were all home birth, non-nurse midwives. I think this would explain the sharp drop in home birth with midwives in Maryland. Prior to that, there were 2 CNMs in Maryland and 1 MD who attended most of the home births in Maryland. Mm-hmm. The doctor retired, and the 2 CNMs both moved away.
Well, and there were 2 other CNMs during that period who also had started a birth center around that time, which was the maternity center in Bethesda. And there was a Dr. Brew and Marion McCartney and Barbara Vahey, or Jan, were doing home births in Maryland until the birth center started. And this is a typical thing that happens. They started the birth center and began having a birth center and home birth practice. And then they lost their liability insurance to cover home birth and got privileges at a nearby hospital and became a birth center / hospital practice instead of a birth center / home birth practice. Similarly, another practice of midwives that's based in Virginia who do still attend home births in Maryland lost their liability insurance for home birth at the same time. They also started a birth center, Birth Care in Alexandria, but they maintained their home birth practice as soon as they could get their insurance back a couple of years later, and are still doing home births in Maryland in very small numbers. But it's a challenge. Going back to the first part of that comment, because of that surge of, I mean, there was a climate in the Board of Nursing at that time, which I don't believe any longer exists, that was a very anti-home birth, anti-advanced practice nursing climate. And since the current executive director has been in charge of the Board of Nursing, I believe that climate has changed, that the Board of Nursing is hugely in support of the independent practice of advanced practice nurses, nurse midwives, nurse practitioners, nurse anesthetists, and that has changed in the last few years. And we've been able to change the regulation that we used to have that required a physician's signature on a practice agreement in order for a nurse midwife to practice in Maryland, so that she had to find a physician who was willing to sign a piece of paper that said he would be available to her 24/7 for consultation, collaboration, and referral. And as my partner likes to point out, you would not sign that agreement for your best friend, much less your competition. So that wasn't a really popular thing, and it was very difficult for nurse midwives to find anybody, any physician that would even return their phone call about it, much less actually sign it, unless they were in a hospital-based practice where the midwife was the employee of the physician or of the hospital, and everything was in a very controlled physician extender kind of situation. That has really changed. I think that there are a lot of nurse midwives practicing independently in the state of Maryland, especially in hospitals. And midwives all over the state can now practice without getting a signature, although they still have to jump through the hoop of submitting a plan, a collaborative plan to the Board of Nursing that names at least one physician, although they don't need his signature. So it's a step in the right direction.
Okay. You have a question you want to ask?
It's too long to write.
Oh, okay. Yeah, sure. Go ahead. They'll have to be, if you could keep it quick because we're almost out of time.
Okay. I just want to add to that. My name is Wendy Klein. I'm a history professor, and I've just published a book on the history of women's health care, and one of my chapters is about Fran Ventry, who was the first initially lay midwife, direct entry midwife, who petitioned and got Montgomery County to give her a license. And she describes in the 1970s, when she goes to the hearing where they're trying to prevent her from getting a license, she describes being analyzed by a bunch of public health nurse midwives in the room as being really antagonistic to her. So just curious if you could comment on some of the tensions between the different types of midwives and how that contributes to, the difficulty in sort of bringing them together at times to push for change.
I think the national organizations of midwives, the Midwives Alliance of North America and the American College of Nurse Midwives, have worked really hard in the last few years to find common ground and to build bridges between the two organizations. And there's actually an ACNM-MANA liaison group where they work together with each other and try to find ways that midwives can work together for the health of women. There are so few of us, there's no point in fighting among us.
Okay.
From a historical perspective, just to differ a little bit, I'm always amazed at the degree to which groups without too much power spend time fighting about that little shavings of power that they have.
Yeah.
And one of the things that I know was an impediment in Massachusetts' effort to try to license certified professional midwives was when the American College of Nurse Midwives came out with a statement opposed to certified professional midwives being licensed in this way, and it was used by opponents from the American College, the Massachusetts chapter of American College of OBGYN, as proof that CPM should be certified. It was actually cited again yesterday in the hearing. So these divisions do exist, and it's difficult as people try to retain what political clout they have. It's an oftentimes difficult battle.
Okay. That brings us pretty much to the end of the time we have here. So I really want to thank you so much, both Dr. Jean DeClercq and Mari Breen-Rothman, for your time and your expertise and a wonderful presentation. And thank all of you for joining us. And we hope that you can join us again next month for our conversation about the Maryland's new alcohol tax. Thank you very much. Okay.